Hello friends, welcome back. Earlier I had to cut short my lecture because of the cough issue. I still have it, but I'll try to finish the second part. Actually, it's a lengthy topic. I divided this into three sessions and I'll cover the second part in here and the third part in my next lecture. I was talking about the early goal-directed therapy, the trial which was done by Dr. Rivers, and we discussed some of the definition like sepsis, septic shock, SARS. We'll talk in this session about the sepsis bundles, treatment, fluid resuscitation using colloids versus crystalloids, and some evidence-based studies and some trials. As I said, early goal-directed therapy trial was done on the patient who came to ER who met the search criteria, and the idea was to look at 28-day and 60-day in-hospital mortality using early goal-directed therapy approach versus standard care. Uh, the 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 idea was to maintain the central venous pressure somewhere between 8 to 12 millimeter mercury map equal to or greater than 65, urine output equal to or greater than zero point 0.5 ml per kg per hour. And in the EGDT trial, those patients, the central venous oxygenation had to be maintained equal to greater than 70%. Uh, the results of this study, Dr. Rivers' study, showed that there's a significant reduction in the mortality using the early goal-directed therapy approach versus a standard care approach. You know, so this study, Dr. Rivers' study, concluded that there's a decrease in mortality by implementing this approach. But as I said, this was a actually a single center prospective randomized trial done on very small number of patients. And about 10 years later, some other trials were done which started challenging the early goal directed therapy approach. These three other trials about in 2014, 2015 were conducted. The process trial was done in United States, a RISE trial was done in Australia and New Zealand, and the PROMISE trial was done in United Kingdom. Patients with the suspected sepsis or confirmed sepsis were like randomized either to receive standard care or early goal directed therapy um, care approach. The goals were actually, just said briefly, to maintain CVP, MAP, and the central venous oxygenation and urine output above certain threshold. And was idea was to see is there any benefit in applying this approach versus just using standard care. So in the uh, the in the process trial, they recruited patient who came to the ER who met two or greater than two such criteria. That means either lactate was more than 4 millimole per liter, and they had either refractory hypotension or systolic blood pressure was less than 90, or they required vasopressor to maintain SPP of 90. They were given fluid challenge like a fluid. The fluid challenge in this study was defined as like 20 ml or more per kilogram given over 30 minutes at the beginning of the study. In the RISE trial, similar population of patients were actually enrolled patient with suspected sepsis or confirmed sepsis meeting two or greater than two such criteria. Um, Similarly, in the PROMISE trial, investigator enrolled patient with the who were having known or infection or presumed infection who met two or more search criteria. Same approach like you know, uh, and here they basically defined like refractory hypotension, if the systolic blood pressure was less than 90 uh, or mean arterial pressure was less than 65 after giving 1 liter or more of the crystalloid over 60 a minute. And the hypoperfusion they defined if the lactate level was more than 4 millimole per liter. Now, when you compare the results of this process trial, uh, ARISE trial, and the PROMISE trial with the with the reverse trial, except in the reverse trial, you notice here there was no difference in the in-hospital mortality rate. You know, well, because all these trials they followed the early goal directed therapy approach as well, but only in the Dr. Rivers trial that trial showed that there's a mortality reduction benefit, whereas the other three trials did not show significant difference. So after the conclusion of these three trials, clinician basically started moving away from the early goal directed therapy approach for the management of the sepsis. If you look at reverse trial was actually a single center observational study which lacked external validity, and and look at the that protocol actually required invasive monitoring. And invasive monitoring means a central vein you have to monitor. You have to insert central line to monitor the central venous pressure, and also a lot of extra measures you have to take, like say, more use of more resources, um, more ICU resources, vasopressor, IV fluid administration, uh, more cardiovascular support and mechanical ventilation. Actually, by doing the early goal directed therapy, those patients actually were, ultimately resulted into longer length of ICU stay, and it resulted into more healthcare cost. Another trial, PRISM trial. In the PRISM trial, the investigator did the meta-analysis of the patients who were enrolled in the three trial, PROMISE, ARISE, and PROCESS trial. And the PRISM study results found no significant difference in 90-day mortality in the early goal-directed therapy approach versus usual care. Now, if you look at this graph, patient survival over 1 year time frame did not show significant difference between early goal-directed therapy approach versus usual care. There was a there was a some concern about the PRISM trial itself as well, because majority of the patient in the standard care group also received fluid resuscitation and received vasopressor. So it was not a simple usual care, because by the time they randomized these patients, every patient had received some antibiotic, and or at least on an average they received 2 liters of fluid, before they randomized into early goal directed therapy versus the versus the standard care approach. So there was some criticism about the trial itself. Now, what do you basically learn so far? If there's no difference, one trial is showing that there's a difference, other three trials are telling there's no difference. So what do we learn from this so far after all? Actually, after the reverse trial, the management of sepsis has kind of evolved a lot. The key is the early recognition and aggressive resuscitation, giving antibiotic as soon as possible within 1 hour. Invasive technique like central venous pressure monitoring, uh, or the central venous oxygenation more than 70%, those techniques are no longer necessary. That was the conclusion derived from the result of three trials after Dr. Rivers trial. Now, so that's the standard of care has already gone up quite a lot, for the last 20 years. So that itself can be a factor in reducing the mortality in mortality to some extent in this patient. As I said, we'll talk about the CMS bundle. Well, most of the guidelines are actually from the Surviving Sepsis Campaign guideline, or some from Critical Care Society, whereas the 3 hour or 6 hour bundles, these are from the CMS. So you need to be aware of this definition as well, because most of the patient, elderly patient, they have Medicare, and if you do not follow the Medicare specific definition, the Medicare may hold your payment. So it's better to know, like, what CMS requirements are. You know, as I said, like a Surviving Sepsis campaign has more number of physicians all over the world, actually clinician, monitoring it, giving their input and expertise. Where CMS is kind of, I'll say, I don't know. I mean, should I say lagging behind? I know I shouldn't say that, but the CMS is their own like guidelines. So they have the 3 hour bundle and the 6 hour bundle. 3 hour bundle is basically, as soon as the patient comes in, check their lactate level, obtain the culture before you give the antibiotic, give IV fluid, and get the culture, and then give the antibiotic, give IV fluid. And for septic shock patient, like give them 30 ml per kg of the crystalloid. In the in the updated guideline, they recommended to you can use the ideal body weight if the BMI is more than 30. In the 6 hour bundle, basically more or less the same thing, but you can um, repeat the lactate if his initial lactate was greater than uh, 2, whereas in 6 hour bundle for septic shock, repeat the volume status, reevaluate the volume status, and tissue perfusion, administer vasopressor if the patient is still hypotensive after the initial fluid. They basically combined the 3 hour and 6 hour bundle into 1 hour bundle. What this bundle emphasizes is that treat the treat sepsis as a medical emergency. That means within 1 hour of the presentation of the patient, I mean, you need to check the lactate, obtain the culture, give broad spectrum antibiotic, fluid resuscitation, use vasopressor if you have to, for those who have ongoing hypotension, you know, so those are the basically all included in the 1 hour bundle. The time zero means the time of presentation when the patient is coming to the ER. Earliest like moment you come across the patient, there's the time zero. So within 1 hour you have to take all these necessary steps to treat the patient. Now, this slide I just threw in here just to make you familiar with the different abbreviation. For example, best practice statement means that the Surviving Sepsis Campaign that means they are recommending BPS. If you see BPS, best practice statement, means they're strongly recommending it. Similarly, strong recommendation is also, I say, oh, as it's clear, it's a strong recommendation. But if it's a weak recommendation, that means they are just suggesting it. It doesn't mean that it's a weak recommendation. You can still use it, but they are suggesting it as compared to strongly recommending it. So strong recommendation of BPS more or less are the same thing. Now, when we look next couple of slides, I'll be basically what the surviving sepsis campaign guideline says for initial resuscitation. They're recommending 30 ml per kg uh, IV crystalloids within 3 hours. So this is from the surviving sepsis campaign guideline for initial resuscitation. And as far as the antimicrobial therapy is concerned, they're recommending to give IV antimicrobial as soon as possible and within 1 hour of the recognition of sepsis. They strongly recommending broad spectrum, empirically broad spectrum coverage. Uh, and, how about the combination therapy? They are not really recommending. There's a weak recommendation from surviving sepsis campaign guideline. So combination therapy, uh, um, not routine for ongoing treatment of serious infection, including bacteremia and sepsis without shock. So it's a weak recommendation. Uh, Now, uh, in terms of the duration, um, duration, the survival guideline recommend de-escalate the therapy when is appropriate and give a weak recommendation for procalcitonin to help decrease the duration of the antibiotic use. You know, Sometime if you notice especially the ID clinician, they will they will give the start the antibiotic, and they will order the procalcitonin, and every third day, fifth day, or seventh day they will monitor. The idea is if the antibiotic is working, the procalcitonin level should go down too. Sometime you start the patient antibiotic, procalcitonin is still high, that means most likely the antibiotic is not working. So either the earlier suspecting bacteria was wrongly diagnosed, or the bacterial resistance. So sometimes procalcitonin is helpful in giving us some idea if the antibiotic is working or no. You know, uh, but surviving sepsis campaign guideline have a weak recommendation, for the procalcitonin. As far as the duration is concerned, most of the infection they for most of the infection they recommend 1 week to 7 days. But some patient they might need longer than 1 week or 10 days of therapy. For example, if there is a very slow clinical response, staph aureus, bacteremia, um, some patient having neutropenia, or some fungal or viral infection like I'll say fungal candidiasis, viral herpes, or the cyto or megalovirus infection. And shorter courses can be considered if there is a there's a rapid clinical resolution after the source control. Imagine if you had a patient a wound, you took care of the wound, or you excised it, or you drained it. There was some intra-abdominal infection or urine infection. Took care of the source of infection. In those patients, probably shorter course may be acceptable. Otherwise, like 7 to 10 days is the recommended duration of the therapy. Now, as far as the fluid therapy is concerned, initial fluid challenges with 30 ml per kg IV crystal oil. how do they determine this 30 ml per kg? Basically, this was done, this was concluded based on many observational studies, and they found it was around like 27 ml per kg. So they rounded it up to 30 ml per kg. It's not a set rule that every patient has to have 30 ml, but on an average, 30 ml per kg kind of works as a bolus if given within um, 3 hour, Um, so the Surviving Sepsis campaign recommending this thing. How about balanced crystalloid saline for initial resuscitation? That's a weak recommendation. How about albumin versus normal saline? Albumin weak recommendation. In the next lecture, actually, the I'm going to cover albumin and the other crystalloid and the fluids in detail about the in the so um, and and the about the hydroxyethyl starch, they are saying no. They strongly um, recommending not to use hydroxyethyl starch for fluid as a for fluid resuscitation. Now, when it comes to choice of fluid, you have a couple of options there. Crystal versus colloids. Colloids are like albumin, dextran, modified gelatin, or hydroxyethyl starch, whereas among the crystal we have balanced as well as unbalanced fluid. As I said, I'm going to cover those in detail in my next lecture. Uh, in this slide, I just compare the amount of the different amount of the electrolyte like sodium or chloride or potassium or lactate, in different types of solution like normal saline versus lactate ringer or plasma light or plasma light 148. Basically, if you look at normal saline, 154 of sodium, 154 of the chloride, where lactate is only 130 meq per liter of the sodium and about on 28 meq of the lactate, and the chloride is 109. So in terms of chloride, lactate ringer is more closer to plasma, whereas normal saline has more amount of chloride as compared to our plasma in our blood, which is around like 100 meq per liter. You know, now uh, and I just talked about this, but let me give you some uh, basic idea about I'll say sodium and chloride in our blood, and in our like and in normal saline. Normal saline is about 154 meq of sodium, 154 meq of the chloride. Like in per liter of the uh, solution basically. Uh, in terms like sodium is almost same as our what is present in our blood, where the chloride is more in the normal saline. So in a way we can call it is unbalanced. It's not balanced as compared to our plasma electrolytes. So in order to make it balance, you need to bring the chloride level down to somewhere around 100 meq per liter. Generally, in the lactate ringer, they add lactate or acetate to make it more balanced, osmotically. Um, so similarly, we have some other fluid like plasma light or Hartmann solution. Which are more balanced, as compared to normal saline, because when you use a balanced solution, they are shown to be associated with the reduced perioperative mortality in ICU and ICU morbidity. The problem is if you excuse me, if you keep on giving many liters of normal saline, which contains, because each 1 liter contains about 54 meq of chloride more than what is supposed to. So if I end up giving 5 liter of normal saline, I end up giving about 270 MEq of chloride more than what my body needed actually. Body as such is neutral. So I introduce more chloride which is negative charge. Body as such is neutral. So what body will do will eliminate the bicarbonate. So in order to maintain the electrical neutrality, So this too much chloride actually can lead to we call hyperchloremic metabolic acidosis, because on one hand you introducing chloride, on the other hand body got rid of the bicarbonate, so it become acidotic, so it became the anion gap can be the same, because you're substituting chloride with bicarbonate, but in terms of anion gap gap will be same, but you introduced like metabolic acidosis, which is not good, so and sometime I'll be discussing in detail some with the evidence-based some references, about the difference between lactated ringer and normal saline versus some albumin, so um, let's start here with a couple of review articles here. This was the um, this was a systematic review and meta-analysis of study showing colloids versus crystalloids in for excuse me, fluid resuscitation. And this study showed no evidence that colloids are in general any better than crystalloid in ICU, burn, trauma, post-op patient. Um, for the endpoint of mortality, pulmonary edema, or length of stay in hospital. Therefore, because this is actually a smaller study, we need to have larger, well-designed, I'll say, a randomized study to achieve sufficient power to detect if there is any real potential difference in the treatment effect, to differentiate crystalloid versus um, colloids. This is another trial called SAFE study in which this was one of the largest study where they compared the albumin 4% with normal saline for fluid resuscitation, and then they found there's no difference in 28-day mortality, which was the primary endpoint for this study. There was also no difference in new organ failure or need for renal replacement therapy or duration of mechanical ventilation, excuse me, in ICU or hospital length of stay. However, if you the one I highlighted in green, the subgroup analysis, which was not powered to detect the difference, there was a significant mortality benefit for trauma patient who received normal saline, which may be due to the number of patients in the trauma group with TBI, where 4% albumin may lead to increase in intracranial pressure, leading to higher mortality. In patients with severe sepsis, there was some benefit seen in albumin, but statistically it was not significant. Therefore, another study uh, was done, which I'm going to come in the next slide. I just want to tell you about the why normal saline a little better here than albumin. If we look at traumatic brain injury, for example, in the brain skull, it's a hard area, like nowhere to expand. The tissue, injured tissue, or when you get injured, the tissue swells up, But imagine if the brain swelling, there's nowhere to go. So what's going to do is going to push against the outer wall of the skull, but that happens to be hard. So what will happen, it will push upon itself, what will happen? It will squeeze its own blood vessel, so the supply to the brain will be compromised whenever you have TBI, traumatic brain injury, bleeding in in the brain. So generally we try to avoid using lactated ringer or hypo or any hypotensive fluid. Because why? Because number, because hypotensive, any hypotonic, not hypotensive, I'm sorry, hypotonic solution, any hypotonic solution will actually leak out into surrounding, creating, making the problem even worse. So usually we use hypertonic solution 3% or even 23.4% solution in TBI patient, and we try to avoid hypotony because that can aggravate the situation even more. So I mean, probably that's the reason we maybe normal saline a little better than the albumin in TBI patient who had increased ICP. Now, this was another trial called by the name called ALBIOS, which stands for Albumin Italian Outcome Sepsis Study. This was done to evaluate if you maintain the albumin level greater than 3 gram per deciliter, will it improve any mortality in severe sepsis or septic patient? Basically, patients were divided into two groups. One group who received 20% albumin and crystalloid, and the other group called crystalloid group received just crystalloid solution alone. And they were randomized to look at 28-day or discharge from the ICU, whichever came first. This study results show that even though albumin was maintained greater than 3 gram per deciliter, or if you calculating in terms of liter, you can say 30 gram per liter, and these patients had a higher MAP. They were on vasopressor inotrope for shorter duration. They had lower net fluid balance in first 7 days. All of this did not result in lower mortality benefit. So here, the thought process is albumin seems to be, it can be a little better than no, just plain saline, but this trial showed no. Albumin is also not, for fluid resuscitation fluid, there's no additional benefit of using albumin over the normal saline. And when you look at the subgroup analysis, then which was basically the secondary outcome, um, um, or all cause mortality. Um, this shows this survival benefit of albumin in patients with septic shock, who were in septic shock group. But this was a post hoc analysis, which means analysis which is done after the study has been concluded. If you look at the graph in the towards the left, they are overlapping, but all the way toward the right, this you see slight slight separation. So that's kind of 90-day time frame. So you see some difference around 90-day, but that's not part of the study. The part of the study was 28 days. So this post hoc analysis show some difference with albumin versus normal saline, So, but it was, as I said, post hoc analysis, so it was not actually part of the data to be um, um, like evidently concluded. Now, similarly, as I said already, even surviving sepsis campaign, then strongly recommending not using hydroxyethyl star. Similar, this chest trial did a study on the hydroxyethyl star versus normal saline on about 7,000 patients. All were critically ill, like for fluid resuscitation. Study showed that there was no difference in 90-day mortality, and there was no difference in the subgroup analysis of predefined group. overall, I will say there were there were more side effects associated with the hydroxyethyl starch group, the one I highlighted in the green, because those patients with the hydroxyethyl starch group end up receiving more renal replacement therapy, as compared to the other uh, other group. Now, now we looked at some of the meta-analysis and systematic review article. Uh, we looked at the SAFE trial, ALBIOS trial, CHESS trial, and none of these studies show any compelling evidence in support of colloids over crystalloid, yeah, basically. I mean, so in my next this thing, I will continue with the uh, um, uh, let me cover the hyperchloremia a little bit here. Then I'll continue with the fluid in my next lecture. So this is basically another um, uh, trial, another study done on about 2,000 patient um, with sepsis, septic shock, with hyperchloremia, with chloride equal to or greater than 110 mQ per liter if it was on if present on admission, and if persisted for 72 hours of ICU stay was independently associated with increased mortalities. Something significant to learn. So 110 MEQ chloride at the time of admission and continuously elevated for 3 days, more than um, 110 or equal to 110 is independently associated with increased mortality. So that's one of the reason we try to uh, avoid giving too much chloride, like giving unbalanced fluid can be problematic if the chloride is too high. But other study we said there's no difference. So what do we learn so far? Basically depends how many uh, total liters you're going to give to the patient. For example, in this study, if you this study show basically if you're giving more than 7 liter so more than 7 liter of the unbalanced fluid, they are I mean they are at at risk of more renal replacement therapy. If it's less than 7, probably you're okay. That's one of the reason we end up using normal saline a lot in our in our in our hospital. So uh, 7 liter is kind of the magic number, I'll say. If you have to give a few liter, probably okay with normal saline. But if you're giving if you need patient need a lot of fluid resuscitation, then maybe you should consider giving balanced fluid versus unbalanced. uh, well, I guess I'll stop here. I'll continue with the fluid management in my next part three lecture. And thank you very much for watching. Thank you.